Ladies and gentlemen, good morning. My name is Rehan Haidry, and it's a real pleasure to be part of this fantastic Rocky Mountain Endoscopy course. I'd like to thank the organisers. I'd like to thank Professor Wani for the invitation, and I'd also like to apologise for not being there in person. I'm going to be talking to you about the role of artificial intelligence in the upper gastrointestinal tract. These are my disclosures. So, why is this so important? We know that there's a rapid rise in the incidence of esophageal cancer in the Western world. And we know that if we can find early disease, we can treat it with minimally invasive endoscopic treatment. And the problem is that we are still not only diagnosing patients late, but we are missing early cancers. This is a historic meta-analysis from the UK showing a combination of studies looking at esophagogastric cancers, and we see that up to 10%, so 1 in almost 400 upper endoscopies would have had a quote-unquote normal upper endoscopy in the 3 years preceding their diagnosis, and 6% in the first year, suggesting perhaps an overlooked early neoplasm. Why do we need to improve? This is Sachin's work, looking at the rate of post endoscopy esophageal cancers over time, up to 26% for early cancer and high-grade dysplasia. So, this is really unforgivable in an age where we have access to such wonderful endoscopic therapies. And we know that if we detect disease early, we improve survival. And this is evidenced by this, looking at squamous cell neoplasia of the esophagus. And ladies and gentlemen, we have a plethora of survival and long-term durability data on endoluminal therapies in the esophagus with advanced resection and ablation in the stomach with endoscopic submucosal dissection. And we know that it doesn't just work in the short term, it works in the long term. So when we look down our endoscope, what do we see? We see very simple things. We look at the mucosal pattern, we look at vascular patterns, and it is anomalies in these that help us to interpret and diagnose irregularities that will point towards inflammation or indeed neoplasia. We know that featureless amorphous mucosa is indicative of an early cancer, in the same way that we know that when we get neovascularization, engorged, dilated blood vessels, this is indicative of cancer, and we should be sampling this. You'll see during the live cases over the next few days, the quality of endoscopic imaging. We are absolutely sprawled. We've packed millions and millions of megapixels into those CCDs. We have monitors that are just phenomenal with ultra high definition and 8K and so much post-processing that we can't keep up with it. And this is not just with conventional chromoendoscopy, but with virtual chromoendoscopy now, we can guide therapy real time, which is really exciting. Lots and lots of diagnostic criteria exist in Barrett's esophagus. This is the Bing classification for classifying Barrett's dysplasia with Olympus. This is the BLI classification from the Amsterdam group. And this is our classification from London. Sachin was part of this group looking at iScan, looking at normal and abnormal pit patterns. So we know that endoscopically, if we categorize these morphologies, we can diagnose cancer. Early squamous cell cancer, what we look at is IPCLs, ladies and gentlemen. So we look at the distortion in these intrapapillary capillary loops, and they help us to diagnose different stages of cancer. This is the Japanese classification, looking at the different types of IPCLs. And you can see that type B1 and by type B2, if you can diagnose this with magnification endoscopy, indicative of early squamous cell cancer that is confined to the mucosal layer and amenable to endoscopic therapy. And even with experts, ladies and gentlemen, you can see that there is a discordance in terms of diagnosing and agreeing on these classifications. And so we need to make this simpler. Even experts 1 out of 10 times will miss a subtle lesion. We're doing lots and lots of endoscopies, and we need an adjunct to standard practice, almost a little angel on your shoulder that will improve your accuracy and just give you that comfort level when you know that you may have missed something. And data is becoming cheaper. Computers are so fast. They've gone are the days that you had to have massive external hard drives. They're packed into super processors now. And this is evidenced by the huge rise in artificial intelligence, not just in science, but everywhere else around us. The cars that we drive, the mobile phones that you use, the airport check-ins, and this is flying in medical healthcare, ranging from deep learning to machine learning, but ultimately what I'm going to talk about now, which is artificial intelligence, the creation of neural networks that we can train, and we can use the ground truth that is experts like most of you in this room that will form the basis, the thresholds by which we will train these neurons over and over again and feed them more and more data so they specialize over time and help us to diagnose early cancer. Let's start with early squamous cell neoplasia of the esophagus, a real favorite of mine, as Sachin knows. Lots and lots of studies, ladies and gentlemen, a couple of these from our group. This was published a couple of years ago with our colleagues in Taiwan, seeing if we can real-time diagnose early squamous cell cancer of the esophagus. So we know that early squamous cell cancer of the esophagus is very difficult to detect and involves not just a trained eye, but also magnification, chromoendoscopy to look at these IPCLs. You can see how subtle this is. This is an early carcinoma in situ. And by taking tens of thousands of these images, we can create these high resolution heat maps that allow us to distinguish between abnormal and normal. And this data that was published with our colleagues in Asia, if you look at the AI system compared to the experts, it fared almost as well, at accuracy of nearly 92%, sensitivity and specificity, which is highly acceptable. And look at that area under the curve, 0.958. This is real-time decision-making on depth of invasion. You can envisage a situation in your endoscopy suite, ladies and gentlemen, where you're doing an endoscopy, you see an area that is abnormal, you magnify, you get an image, you plug this into your image classifier, and it comes up with a prediction that confirms what you think is a type B1 IPCL. Go forth and deliver local therapy, and we will not undertreat this patient. And this is where we need to head to. Let's talk about Barrett's, a real center of excellence where we are now in terms of Barrett's research. But we can't shy away from the fact that this is so boring, doing Seattle protocol biopsies. When you see one of these on your list, you go looking for your fellow to rapidly take the scope off you so that you can go and watch paint dry. But there is now a plethora of data looking at artificial intelligence in Barrett's esophagus. This is really by far the most phenomenal work so far by Jacques Bergman's group in Amsterdam, published in Gastro a couple of years ago. Deep learning to look at these heat maps that they generated, and real set the benchmark for the rest of us. A computer-aided diagnostic system. Look at the accuracy there of 88.2%, but it falls below PIVI. How can we do better? This has just been published in the last few months by our group, looking at lots and lots of images. We took tens of thousands of images, and then we got experts from around the world to delineate these areas of abnormality. And this is what we use as our ground truth. I won't even begin to understand what this means, but our computer scientists tell me that this is what a CNN looks like, but this is what came out at the end. When we looked at the area under the curve using enhanced imaging, but also white light endoscopy, we had really, really good outcomes, a sensitivity of 91% in terms of detecting dysplasia. So this is real-time decision-making with these heat maps. If we then look at targeted biopsy predictions using this model, the CNN was on par 98% of the time. So look at this, ladies and gentlemen. This is real-time decision-making. This is a patient referred to our center for endoluminal ablation. And the key here is we mustn't undertreat these patients. We must look for visible neoplasia before we treat. So I'm using this AI system that we work with called Odin Vision, which is now the first commercially available system. I've got a distal attachment, and you will see that I'm just very carefully, first of all, doing a normal endoscopy that all of us would do before I actually bring in the AI system. You know, I always say garbage in, garbage out. You need to know what you're looking for. You need to know what question you are asking. So you will see here that I'm just beginning to interrogate this area, and there's something here that's caught my eye. And this is where now with magnification endoscopy, you can start to make your own endoscopic diagnosis. So you can see these are beautiful, nice, normal pit patterns. I'm just going to forward this video now to an area that is abnormal, and then I'm going to show you where the AI system comes in. So here, if you just look at the bottom right, sorry, I'm just going to stop there. Now I'm going to ask the computer, where is the dysplasia? And it was already demarcated for me there on the posterior wall. And what I'm going to do now is I'm going to magnify into that area. And again, we're going to ask the computer, where would you take your biopsy from? And it shows you real time. So just in the confines of time, I'm going to skip over that. But how can we use this? That's a sort of, you know, a pan image of the esophagus, but we've just submitted this data to GI endoscopy, and this is again in collaboration with Odin Vision, and we have perfected our neural network. And you can see here now, this is with magnification endoscopy. You know, where can I put my dots before I do my ESD? And you ask. This is real-time decision-making. The computer is looking at this area on the posterior wall. You can see it's dysplastic. And this is with, you know, magnification. So really handsome pictures, just confirming to you where you are going to, you know, guide your therapy. So, you know, this data will hopefully be in the public domain and will allow us to be in this situation where you will look at an area. You will think it is non-dysplastic. You will characterize it on magnification endoscopy. You'll get a heat map, and you won't even need to take a biopsy. Gone are the days of Seattle protocol biopsies. Or you'll look at an area, this is abnormal, I need to resect this. Please tell me, am I right, am I wrong? And number two, where should I put my delineation mark so I don't undertreat this patient? It will reduce unnecessary sampling, and it will make our endo resection more accurate. To finish off, this is sort of ugly duckling of upper GI endoscopy, which is the stomach, you know, big cavity with lots going on. But it's really important that we know what normal is, and there's lots of blind spots in the stomach. And what are the questions we need to look at? Helicobacter pylori infection. We need to look at CAG, chronic atrophic gastritis, and IM, and ultimately early gastric cancer. And again, lots and lots of studies. These are precancerous studies looking at CAG and Helicobacter pylori, and then look at this, loads and loads of data emerging on early gastric cancer, but also prediction of depth of invasion. This is published by our colleagues in Wuhan, really smart study. And look at the cursors on the left. So again, this is real-time decision-making. You're looking at an area here on incisura, and look at the freeze image, and your computer-aided tool will tell you this is chronic gastritis. And if you now look at an area where you have atrophy, but also you have metaplasia, so again, you need to know what you're asking the computer. So they're using a little bit of enhanced imaging. You can see on the incisura there is a slight area that is amorphous, and you have this characteristic sort of areas of intestinal metaplasia. And when you take a freeze image here, you will see GA, gastric atrophy with intestinal metaplasia. Conversely, if we now are going to ask the question, is there cancer here? You can see that, again, a subtle area here, which looks abnormal. I'm just going to forward this for the confines of the, sorry, go on to the next video. Sorry, this is talking about EndoAngel, which is supplied by our industry partners. And this is a subtle depressed area here. You can see on the lesser curve, and again, real-time prediction this is an early cancer. You can see that yourselves, the amorphous area is slightly depressed. I've run over slightly, but ladies and gentlemen, you've seen just a snapshot of how exciting the future of endoscopic imaging is. We mustn't hide away from the fact that we need to, as clinicians, as endoscopists, invest in learning the different imaging modalities. We need to equip ourselves with understanding what is normal, and then abnormal will follow. But we need to embrace the fact that we still are underperforming, and we need to embrace technology. We need to embrace artificial intelligence, because the more we detect, then all of you will carry out all your clever, minimally invasive endoscopic treatments, and these adjuncts are here to stay. So listen, thank you very much for your time, and I look forward to taking any questions.